Happy Forgotten Infection Friday. So today, let's just dive into it. A 62-year-old male with poorly controlled type 2 diabetes presents to the hospital with 6 weeks of worsening cough, fatigue, night sweats, unintentional weight loss, increasing shortness of breath. He reports no recent travel, no known tuberculosis exposure, and no smoking history. At first, everybody thinks it looks like tuberculosis. So, vital signs: low grade fever, elevated heart rate, oxygen sat slightly reduced. Blood work shows hemoglobin A1C of less 7.6, elevated glucose around 182, elevated inflammatory markers like CRP, ESR, chest imaging. So the CT chest scan shows multiple lung nodules, areas of consolidation, and cavitary lesions. And the radiology report raises concern for tuberculosis, fungal infection, and malignancy. Now, because the patient had unintentional weight loss, night sweats, and lung cavities with nodules, the clinical team suspects pulmonary tuberculosis. Sputum testing was performed, but the TB tests are negative, symptoms continue, and imaging worsens, and the patient is not improving. So they do a bronchoscopy, and it was performed, and a lung sample was taken and examined. A gram stain showed branching filaments, gram-positive organisms. They look almost like fungus. A modified acid-fast stain is performed. Results are I say weekly, weak, weak acid-fast branching bacteria. This is a clue. They have diagnosed the organism as Nocardia species. So, what is Nocardia species? It's a weak acid-fast branching bacteria. Okay. So today we're going to talk about Nocardia species. So let's break it down. So it's a branching bacteria. So Nocardia, when they say weak acid-fast branching bacteria, tuberculosis is acid-fast, but I believe if I'm wrong, I will correct myself. But this is Nocardia, I'm sure it's Nocardia, is a branching bacteria. So this refers to the shape and the growth pattern. So instead of appearing as simple rods like E. coli or spheres, like circles, right? Like Staphylococcus, this bacteria grows in these long filamentous like rods, thread like structures, branching networks, and similar to fungal hyphae. So under a microscope, they look almost like tiny pieces of tiny tree branches, and tangled threads. And this is example of nocardia or actinomyces. Okay. So when we say acid fast, what does that refer to? Acid fast refers to the ability to hold a special stain called the Ziehl-Neelsen stain. And if I pronounce it wrong, I'm going to spell it out. Ziehneelsen. Neelsen. Okay. So the reason for this is that many acid-fast bacteria have these waxy lipid called mycolic acid in their cell envelope. And these lipids make the bacteria, one, resistant to being washed away by the acid alcohol during the staining, makes it harder for the immune system to destroy, as well as makes it more resistant to environmental stress. Classic example would be Mycobacterium tuberculosis. Can you see why it was misdiagnosed like that? Because Mycobacterium tuberculosis is a strong acid fast, but Nocardia, Nocardia, if there's a more fancier way of me saying or pronouncing it, please tell me. But nocardia is called a weak acid fast bacteria because it has some mycolic acid, but not as much as the actual mycobacterium. So let's just do side by side. So the mycobacterium has lots of mycolic acid. It stains fast and strongly, okay? Nocardia has some mycolic acid. It partially holds the stain. That's why they're calling it a weak acid fast, okay? So the lab clue is that they may stain positive with some modified acid fast stain, but they also may lose the stain with a stronger acid washing. So why does this matter to us? So nocardia can be confused with other organisms because it has features from both worlds. It looks like fungus because of the branching filaments, and it acts somewhat like a mycobacterium, which, why they say weak acid fastness, right? And this is why patients, like if a patient has diabetes, chronic steroid use, cancer treatment, transplant, or immune suppression can be misdiagnosed, and a lung biopsy or sputum sample might show branching organisms, but the doctor has to distinguish between nocardia, mycobacterium, an actual true fungus, things like that, okay? But the twist is that on further imaging, because nocardia has a dangerous habit, it spreads, okay? It's called dissemination, and it spreads. So MRI on a brain could show these ring enhancing lesions, and it appears to be a brain abscess, but the culture will confirm that it's nocardia farcinia, and the patient would have what they call pulmonary nocardosis with brain dissemination. And in medicine, some infections announce themselves loudly. They may have fever, dramatic symptoms, and obvious lab abnormalities. But nocardia is different because it is a slow moving, deceptive infection caused by a bacteria that can behave like a fungi, hide from immune defense, and often get mistaken for something else. And I don't think people understand how dangerous the world of misdiagnosis is. It plays a huge role and it can delay treatment. So that's why the whole point of medical school being so strenuous in so many years, and why you're learning even these very rare cases, because if you miss the rare case, it could actually, the results can be horrible, might be hard to treat, or it might be too late to treat. Okay. So let's always keep that in mind. So let's go into nocardosis, okay? So this bacteria or this infection was discovered by a gentleman, a microbiologist, and a French veterinarian named Edmond Nocard, okay? So surprise, surprise, he named it after him, okay? Uh, I don't know if I would be one of those people who named something a discovery after myself. I really don't know. I don't think so. I think I would name it after a patient if it was me. I would ask them, but, I think if I had a discovery and it was from a patient, I would name it after the patient. So, in 1888, Nocard, microbiologist Nocard, first described this organism called Nocardia farcinia, or Nocardia species, which was studied while they were studying bovine farcy, which is a chronic infection in cattle. He isolated the bacterium and showed that these are a filamentous branching bacterium from infected animals recognized with this new organism, and they named the genus Nocardia in his honor. Okay, so he discovered it in 1888. In 1890, Epppinger reported the first recognized human case of nocardia, a lung infection caused by nocardia. And later, microbiologists classified it as a group of aerobic weakly acid fast branching gram-positive bacteria related to Actinomycetes. Okay, these words really get to me. Okay, so let's do the classification of nocardia. So Nocardia domain is a bacteria. Family is okay. The phylum is Acetobacteria, and family is Nocardia. I wish my tongue can roll the way it needs to make these sounds so much fancier, but yeah, no. But so we know that underneath the microscope, it has a very distinctive look, nocardia. So the appearance of nocardia underneath the microscope have a very distinctive look. With a gram stain, it shows these branching filament-like structures. It is gram-positive, almost looks like fungal hyphae, and this is one reason it is very much confused, okay? Now let's go to the biochemistry of it. So the cell wall of nocardia, it has peptoglycan, so that provides structural strength, but it also has mycolic acid, and these create resistance from drying, protection from chemicals, and immune evasion. And the waxy layer makes antibiotics penetrate much slower. So why does it have branching nocardia? It grows in as these long branching filaments. And this happens because the bacteria grows through what they call apical extension. And that's meaning that the growth occurs at the tip of the bacterial filaments. Reminds me of a little bit of telomeres. If Reminds me a little bit of telomere, and this creates a network similar to fungal hyphae, and the result will be a bacterial colony that looks like mold. So how does somebody get nocardia? So main roles, the most common is through inhalation. So a person breathes nocardia through soil particles, dust, and contaminated air. So bacteria usually goes from lung to bloodstream to organs. Another one is direct skin inoculation through cuts, puncture wounds, and soil contamination. So this is quite common in gardeners, farmers, and construction workers. Now, let's do the pathophysiology, how nocardia causes disease. Step one is entry point. We talked about the two one, either through lungs, inhalation, or through damaged skin, direct skin inoculation, right? Step two, the immune system recognition. So the body detects it, the cell bacterial wall components, and the foreign proteins. The macrophages are trying to attempt to destroy it. Step three, the problem is survival cells inside, right? So the nocardia can survive. It's so weird. It can survive inside macrophages. And it uses several strategies to survive inside the macrophages. Oh my gosh, this is like a nightmare when it comes to diabetes. So it blocks the oxidative killing. So normal macrophages produce the reactive oxygen species, the reactive nitrogen species. These destroy microbes, and nocardia can resist this attack. So the enzyme defense, nocardia produces enzymes such as catalase, which breaks down hydrogen peroxide, okay? And this protects the bacteria from oxidative damage. Mm-mm-mm. Superoxide demutase. This converts superoxide radicals to hydrogen peroxide, reducing the damage from oxygen radicals. Now, the immune response. The body tries to contain the nocardia bacteria by forming something called granulomas. These are clusters of macrophages, giant cells, and lymphocytes. This is very similar to tuberculosis. The immune system is basically trying to build a wall around the infection. But I want to call it Norkia, but Nocardia can escape slowly from this. Okay. But the clinical presentation, the most common form of nocardia is pulmonary nocardosis. And the symptoms would include cough, fever, night sweat, fatigue, weight loss, shortness of breath, and chest pain. Imaging will show nodules, cavities, infiltrates, and masses. The problem is it looks like it could be cancer or TB. Now, disseminated narcodosis. The bacteria enters the bloodstream. The most common target for it, right, after like the lungs, would be brain abscess, causing a brain abscess, unfortunately. So symptoms like headache, confusion, weakness, personality changes. The patient may present like they're having a brain tumor. Skin narcodosis, abscesses, ulcers, cellulitis like infection, drainage sinuses. So as you could see, they survive in macrophages, right? So why is diabetes a major risk factor for this? Because especially with diabetes, right? What do you think is happening? What happens to our immune function with diabetes? It's completely compromised and dysfunctional, right? So how does diabetes help this bacteria nocardia? Nocardia. So the neutrophil dysfunction, that's a big role. It's usually because of the hyperglycemia. So neutrophils are the body's first defense system. The high glucose, aka hyperglycemia, impairs the chemotaxis, which is the thing that allows the defense system, the cells, to movement towards the infection. Phagocytosis, which is the engulfing of the bacterium and killing ability. So the bacteria has more time to multiply because the defense system of the immune is very weak. The poor oxidative killing, the neutrophils that kill the bacteria using oxidative first, diabetes actually reduces this effectiveness. So the nocardia already has this defense system against oxidative stress. So it's like a win for nocardia, a loss, in that patient's body because their oxidative bursts are already compromised because of the diabetes. Okay, so this combination is quite dangerous. Next is because diabetes causes reduced blood flow, microvascular disease, and impaired repair, right? Meaning that once an infection starts, the clearing of the infection gets quite harder. And then high glucose environment, we already know. That's why we tell you control the glucose level, your hypoglycemia. People just think it's just to see a number get lower on the digital meter, whatever, not whatever, but the digital meter that tests it. No, this is you're trying to pretty much regulate your entire body because it literally causes a whole cascade of events. I always try to make people remember, have you ever seen a disease with one symptom? It's never just one symptom. That's why even when it comes to diabetic foot ulcers, right? It's not just the diabetic foot ulcer. It's never just the diabetic foot ulcer. It's the whole body. It got so bad that it made a diabetic foot ulcer that the body couldn't heal on its own. I mean, if there's a foreign body, we'll get to that. But it's really the diabetes taking over in the entire body, and it's like a skin manifestation of the diabetes on the foot. It's it has you have to treat the patient as a whole when it comes to a diabetic foot ulcer. When it gets to a diabetic foot ulcer, we have to recognize and remember, and I'm just being on a side tangent, that this is a whole body problem now for it to get this bad on the foot. And definitely need vascular, they definitely need a full workup, they definitely need endocrinology, they definitely need vascular, and I'm not just talking about just vascular for your lower extremities and just saying ABI or arterial duplex. I'm saying cardiology, okay? Because a lot of our patients that have diabetes, they have cardiology issues because the diabetes, remember, it's like molasses with their blood and it causes also calcifications. This is more than just a foot problem when it comes to diabetic foot ulcers, okay? And if the goal is to increase the quality care of our patient's life as well as their longevity, we have to target everything at once, okay? That's why they say a multidisciplinary team, because once a diabetic foot ulcer shows up, it is not just one system, it's multiple systems that are involved now, okay? It's never one system, it's never just the foot and the poor, let's say, peripheral arterial disease when it comes to that hypertension, cardiovascular disease, a bunch of things, okay? So always keep that in mind. Now, back to the nocardiosis, okay? So nocardosis is famous for imitating other diseases, like it usually gets commonly misdiagnosed as tuberculosis. Why? Because both cause a chronic cough, weight loss, night sweats, lung cavities, and granulomas. The patient may be placed on TB medication, unfortunately, while they have nocardia that is growing, okay? Another misdiagnosis for narcoidosis is lung cancer. So, imaging may show this solitary mass or multiple nodules. A physician may suspect malignancy. Biopsy reveals it's not a cancer, but an actual branching bacteria. Now, another misdiagnosis for narcoidosis is fungal infection because it looks like fungi. It can be mistaken for aspergillus as well as mold infections, especially in immunocompromised patients. And another misdiagnosis is a diabetic foot infection. So in our patient with diabetes, a wound may be assumed to be typical bacterial infection, osteomyelitis, or polymicrobial. But narcodosis may actually be involved if it produced these chronic draining wounds, slow healing ulcers, or recurrent abscesses. So the key to diagnosis for this is biopsy, looking for the branching gram-positive filaments, as well as a modified acid fast stain, which will show these weak acid fast organisms. If it's strong acid fast, most likely it's mycobacterium. If you have to pick the two, right? With culture, Nocardia grows quite slowly. So it's important to know that the culture for this bacteria, it can take days to weeks. So a short culture period can miss the Nocardia bacterium. Now, another one is molecular testing, like PCR or sequencing can help identify the species much better. So treatment. When it comes to treatment, usually requires prolonged therapy. They love Bactrim. Bactrim is a common treatment for this. Why? Because it blocks the bacterial folate production. In some more severe cases, they might require IV therapy like amikacin or epenamine or ceftriaxone. Duration is usually 6 to 12 months because nocardosis usually hides or nocardia, let me just say the bacterium hides in tissue. So the danger of nocardia is not that it's impossible to treat. The danger is that the treatment begins late because everybody's looking for the wrong enemy. So think nocardia when you see immunocompromised patient or a diabetic patient with steroid use or a chronic pneumonia or lung cavity or brain abscesses or branching weak acid fast organisms, okay? So are there cases of nocardia in diabetic patients who have in patients who have diabetes? There are actually multiple case reports with disseminated narcodosis in patients with diabetes involving pulmonary infection, brain abscess, skin infection, as well as bloodstream spread. And a commonly reported pattern is an older adult who has diabetes, chronic lung symptoms, and delayed diagnosis. And one published example described a patient who had diabetes who presented with prolonged respiratory symptoms, abnormal chest imaging, initial suspicion of tuberculosis or malignancy, but it was later identified as nocardia from respiratory cultures. Okay. And another recurring theme in some case reports of this is that patients were often treated for other diagnoses first because nocardia was not initially considered. And like we said, why it's often misdiagnosed could be misdiagnosed as cancer, TB, fungus, or a diabetic, just a routine diabetic foot infection. Okay. So and there's no such thing as a routine diabetic foot infection. So forgive me for even saying that because there's no such thing. So why is neurocardosis forgotten? Because, and how on our episode of Forgotten Infection Friday, I always look forward to Fridays. So narcoidosis survives because it does not look like itself. It doesn't look like a bacterium. It's a bacterium that looks like it resembles fungi. It's acid fast like it resembles tuberculosis. It's slow like it resembles cancer. It's invasive like an opportunistic infection. So in patients with diabetes, especially if they have a chronic cough, unusual lung finding, brain symptoms, stubborn wounds, Nocardia should always stay on that list because sometimes the infection is not one that screams, it's one that quietly pretending just so it can continue to spread. And I hope everybody loved this episode of Diabetic Foot Files, Forgotten Infection Friday. And I'm Dr. G, and take care of your feet because they take care of you.